Good afternoon, everybody. My name is Abigail Katz, and today I'll be talking about the educational landscape of gender-affirming surgery. I have no disclosures. Before I get started, I'd like to thank the Mount Sinai Department of Plastic and Reconstructive Surgery, our research team, and everyone else for making this project possible. By the end of this lecture, you'll be able to better understand the history and significance of gender-affirming surgery, describe the current landscape of gender-affirming surgery training during plastic surgery residency, and emphasize the need for more training opportunities in gender-affirming care across all specialties. It also just so happens that this week is Transgender Awareness Week, so I'm especially excited to be giving this presentation to help bring awareness to the challenges faced by the transgender community and efforts we can make towards inclusion, increasing access to care, and patient advocacy. In the United States, there are approximately 1.4 million people who identify as transgender. Of the population, this number equates to approximately 0.5% of adults and 1.4% of adolescents. The higher youth estimate has been attributed to younger generations having more access to information, support, medical care, and resources. And so this estimate in the youth may be more representative of the true percentage of the transgender community in the population. In addition to including people of all ages, the transgender community is composed of a diverse group of people from all backgrounds, races, and ethnicities. Although there has been an effort to increase acceptance of transgender individuals, this community has faced an extreme amount of stigma and discrimination, both at work, in school, and in their daily lives. These disparities are also reflected in the drastically higher prevalence of suicidal ideations and suicide attempts among transgender individuals. Other factors reported in the literature that increase risk of suicide include family rejection, mental health challenges, lack of access to care, and not feeling safe in their communities. Given these disparities, it's more important than ever to create an inclusive environment for all transgender individuals. This is especially true in healthcare, and as members of the medical community, we can all do our part to reduce discrimination and work to improve access to healthcare. Although only one piece of the puzzle, gender-affirming surgery, or GAS, is a fundamental aspect of recognizing and respecting an individual's self-identified gender, and it reflects a commitment to equality and human rights. Approximately 15 to 25% of transgender individuals undergo some form of transgender surgery. The positive impact that GAS surgeries can have on the transgender population has been demonstrated in multiple studies in the literature, some of which include improved quality of life, decreased suicidality, reduction of mental health disparities, recognition of an individual's gender identity, as well as positive surgical outcomes, and it enables patient-centered care. There are several types of gender-affirming surgery that can be performed, which you may or may not already be familiar with. Facial feminization surgery is a set of surgical procedures that modify facial features to create a more feminine appearance. It can include forehead contouring, rhinoplasty, jaw reduction, and others. And this surgery has been shown to significantly enhance an individual's facial gender expression and improving their overall well-being. Facial masculinization surgery is similar but the reverse, and it modifies facial structures to achieve a more masculine appearance. And although this procedure is less commonly performed than facial feminization, it has been shown to have similar improvements in quality of life. Next is chest feminization surgery, which enhances the size and shape of the breasts to achieve a feminine appearance. And on the other hand, we have chest masculinization, which involves removing breast tissue and surrounding skin, contouring the chest, as well as changing the nipple size and in some cases location, which often requires the use of a nipple graft. Feminizing genital surgery, which is commonly referred to as vaginoplasty, involves removing and diverting the tissues of the penis to create a fully functioning vagina. And this surgery requires skin grafts and urethral manipulation. Lastly, to create male genitalia, a phalloplasty is performed, and this surgery commonly uses skin and/or tissue flaps from the forearm or elsewhere in the body. As you can see, GIS requires several specific types of surgical expertise and skills to be performed. Many of these skills can be obtained during other fellowship trainings, but apply to GIS. For example, craniofacial and microsurgery fellowships teach surgeons many of the advanced surgical skills needed for these procedures. And although plastic surgery is at the forefront, GIS is a multidisciplinary effort, and there are many medical specialties that can be involved in performing these procedures, not to mention all of the non-surgical fields that are instrumental for overall transgender health. And given the intricacy of these surgeries, there's a strong need for comprehensive training in GIS. To give a little bit of background, although this is a relatively new field, there have been some important historical milestones that contribute to the ability of surgeons to be able to perform these procedures today. Prior to 1952, most of the GIS performed were purely experimental. And in 1952, the first modern GIS was performed in Denmark, which opened the door for these surgeries to be performed all over the world. In 1996, Johns Hopkins opened the first gender identity clinic and started offering gender-affirming surgeries, setting a precedent for formal medical involvement and training in this field. In the 1970s, Dr. Stanley Bieber, who was an extremely influential gender-affirming surgeon, really began popularizing this field and performed a high volume of these surgeries at his practice in Colorado. In 1979, the World Professional Association for Transgender Health, called WPATH, was funded, and this group established guidelines as well as standards of care for gender-affirming surgeries as well as overall transgender health. In the 1990s, there was a slow but steady growth in the number of training programs that offered gender-affirming procedures, although at this time it was still limited. In 2007, the American Society of Plastic Surgeons, ASPS, started to include gender-affirming surgeries within its educational offerings. In 2011, WPATH starts accrediting gender-affirming surgery training programs. And in 2016, the first year-long accredited gender-affirming surgery fellowship program was established in the United States at our very own institution, Mount Sinai. This really opened the door to a realm of training opportunities and growth in this field going forward. In fact, from 2016 to 2017 alone, ASPS reported a 20% increase in the number of gender-affirming surgeries performed, and this growth has continued since then. With this increase in demand, it's more important than ever to continue training surgeons to specialize in these types of surgeries. Despite the growth of the field, the gender surgery educational landscape has not yet been described in detail. And so with this in mind, the purpose of this study was to describe the current gender surgery training landscape and also to examine the program-specific factors that are predictive of institutions offering gender-affirming surgery training. To do this, we performed a retrospective study on plastic and reconstructive surgery training programs in the US and Canada. We obtained our data from November 2021 to February 2022, and we got our data from publicly available sources. We also, in addition to this, contacted program coordinators, residents, and fellows to obtain any missing information and or further clarify any information that was listed online. The variables that we collected included the presence of dedicated gender-affirming surgery rotations, which we defined as a mandatory core rotation where at least 50% of the exposure was in GAS. In addition, we also collected information on the presence of gender surgery fellowships, the number of integrated plastic surgery residents, the presence of a research year in the training program, and the program-specific subspecialty rotation durations. With all of this information, we ran univariate, linear, and logistic regression models to establish relationships between gender surgery rotation duration, the presence of gender fellows, and the program-specific details. In total, 94 plastic and reconstructive surgery programs from the United States and Canada were identified and included in this study. At the time of data collection, only 2 residency programs had gender surgery rotations, one of which was 6 weeks in duration and the other was 12 weeks in duration. The number of months that, the number of months that residents rotated on gender surgery was significantly predicted by having an increased number of integrated plastic surgery residents, having an increased number of aesthetic surgery fellows, and having more months on craniofacial surgery. In summary, the factors that are associated with larger institutions and programs correlated with increased time on GAS rotations, and in addition, the amount of craniofacial exposure was also found to be important. At the time of data collection, 6 residency programs also had gender surgery fellows. And the presence of gender surgery fellows was significantly predicted by having more integrated plastic surgery residents and having a research year integrated into the training program. So similar to having gender surgery rotations, having gender affirming fellows was also predicted by factors that are associated with larger academic institutions. In conclusion, the volume of gender surgery is increasing in North America. However, formalized training for gender affirming surgery during residency remains limited. The presence of gender surgery training is currently best predicted by factors associated with larger academic institutions. These include having an increased number of integrated plastic surgery residents, the presence of a research year during training, and having gender-affirming surgery fellows. In addition, more time on craniofacial surgery was also implicated and likely reflects the high volume of facial feminization and facial masculinization surgeries that are being performed. There were a few limitations of the present study. The first being that we only included information from 2021 to 2022, and so the results do not reflect the amount of growth and changes within the gender-affirming surgery training over time. Second, we only assessed programs that had a core rotation where at least 50% of exposure was in gender affirmation, and we could not account for programs that might offer this type of training as an elective that residents can choose to take on their own. And lastly, we were only able to collect information based on what was publicly available. Despite these limitations, there are several overarching themes based on the findings from the study that are relevant for all medical specialties. First is that achieving the best possible care for transgender patients requires collaboration across an array of medical specialties. We also need to greatly increase the amount of formal training that doctors receive in gender-affirming surgery and all other form of transgender healthcare. And lastly, as members of the medical community, it is extremely important that we lead by example and strive to create environments of inclusion for these patients in healthcare and focus our efforts on providing patient-centered care that addresses the individual needs of each patient for all members of the transgender community. Thank you again to my research team for making this project possible. Here are some of my references. And thank you again for the opportunity to present this project. If anyone has any questions, I'd be happy to answer.
Thank you, Abby. That was really wonderful. Thank you. I am going to pause. If you pull your slides down before we move to Stephen, I am going to ask if there are questions specifically for Abigail on this incredibly important work. Roberto, please go ahead.
Thank you, Abby. That was a great presentation. Very nice work. Do you know if there's any formal efforts to have programs include more formal training in gender-affirming surgery? Is there efforts to make it a requirement, for example, if programs want to be accredited, that they should include a certain amount of training in gender-affirming surgery?
Truthfully, I don't believe so at this time, only because there are so few programs that even have the ability to offer this type of training, given that you need to have like a center for transgender care and surgeries, and you also need to have physicians who are specialized in these surgeries. But I do think that in the future, like I could see that definitely being something that needs to be included.
Good, thank you.
Jacob, go ahead.
Yeah, I'm just curious, in the current political environment, if programs are at all facing pushback from communities or right-wing activists on the subject.
Yeah, I don't know firsthand about the answer to that, but I think that the programs that already do have established training in gender-affirming surgery, you know, have just been conducting their operations as usual. I'm not totally sure if they face pushback. I'd be surprised if, you know, there weren't people who were trying to fight against this type of training and this type of care for the transgender community. However, I don't know if that's like really impacted the educational landscape.
Thank you. Any more questions for Abigail? Well, Abigail, I want to really applaud you and your team for this really critically important work. Thank you again, and congratulations.
Thank you.
Yes, you're getting a Zoom. I hope you're seeing the Zoom love. All right, so now we're going to turn it over for our next Blue Ribbon winner, who also is a wonderful medical student. I'm going to introduce Stephen McCroskery. And Stephen is a fourth-year medical student at Icahn Mount Sinai. He's originally from Connecticut and completed his undergraduate studies at Rutgers. While at Rutgers, Stephen was a member of the Tomb Air Lab, where he investigated the interaction of the ribosome with ricin toxin, a potential bioterrorism weapon, with the aim of informing the rational design of an inhibitor. After college, Stephen came to Mount Sinai for a Master's of Biomedical Science and then joined the lab of Dr. Peter Palesi. His master's thesis was focused on potentiating Newcastle disease virus as an oncolytic agent. During the COVID-19 pandemic, Stephen made key contributions to adapting this virus for use as a COVID vaccine named NDV-HXPS. This vaccine is currently in phase 3 clinical trials in several countries. During medical school, Stephen created assays and standard operating procedures in support of a phase 1 clinical trial held at Mount Sinai evaluating that vaccine as a COVID booster. And then he transitioned to more clinical research focus and participated in several projects, including research in outcomes of androgen receptor targeted therapy in metastatic prostate cancer. Stephen is currently applying for residency in internal medicine, and we're really delighted to have him present another area of expertise and work in medical education. Welcome, Stephen.
Okay, thank you. Let me just bring up the slides. Okay, can everyone see? Okay, perfect. As you just heard, my name is Stephen McCroskery. Really excited to be speaking here today. I'm going to be presenting a quality improvement project where we aim to increase utilization of home sleep apnea tests at the IME clinic, which is the resident run clinic out of Mount Sinai. Before I begin, I just wanted to mention all the hard work that got put into this project from people such as Mitchell Gronowich, who is a PGY3 here at Sinai, Jessica Farley and Julie Huang, who began this project as nursing students and now are full-fledged nurses, and Dr. Jing Wang, our mentor. No conflicts of interest. Okay, first, a little bit of background about obstructive sleep apnea. So it's a highly prevalent disorder. It's estimated that about 17% of males 50 to 70 years old have the disorder, and females are 9% during that same age range. One thing that's important to note is that while a lot of people have this disorder, there's a lot of people that are undiagnosed. And surprisingly, around 50%, according to some people, actually don't have diagnoses of sleep apnea, even though they do have the disorder. And there's a myriad of complications and goes really beyond the decreased quality of life and daytime sleepiness, namely cardiovascular disease, hypertension, heart attack, stroke, insomnia, and depression. Overall, just an increased risk of comorbidities and mortality. So given the prevalence, it's something that people are really concerned about and actively thinking about getting more people to the table and treated. So there are two types of studies to evaluate for obstructive sleep apnea. On the left side, it shows polysomnography, which occurs in the lab. So if you look at the picture, this person is covered in all sorts of sensors. It's EEG, EKG, band, and what's not really the evident from this photo is that he's actually in a lab somewhere. But it is a gold standard test for obstructive sleep apnea and a wide variety of other sleep disorders. But as you can probably gather, it's uncomfortable, it's expensive, and given that there's limited capacity in sleep studies centers, it can take a long time to actually get into the clinic to be tested. On the right side, there's a photo of a patient sleeping comfortably in bed wearing nothing but a wristwatch with a suite of sensors, as well as a pulse ox. So that's a home sleep apnea test. It's more comfortable, it's less expensive, and there's less constraints about the availability of these tests, so people can generally get these tests done much more quickly. And some people are thinking that it can serve as like a quicker pathway to getting diagnosed and treated. Briefly just wanted to touch on the state of obstructive sleep apnea care in the US. So across the board, in most places, you're going to be waiting a long time to be treated and evaluated for obstructive sleep apnea. A lot of different reasons for this, but one of the most commonly cited reasons is that there's a shortage of sleep medicine specialists. And not only does this translate into increased time from clinical suspicion of OSA to treatment, it's been shown that it has negative effect on CPAP adherence. So the American Association of Sleep Medicine put together a schematic, which we're calling a hub and spoke model, for potential avenue for increased PCP participation and coordination with sleep centers in order to facilitate faster diagnosis and treatment. So if you can look at the diagram on the right, in the center is a regional accredited sleep center that handles the more complicated care, as well as the interpretation of the studies and treatment. And in the periphery are the spokes, which are PCPs that are knowledgeable and comfortable in the different variety of sleep studies out there and know which patients are most appropriate for which ones. So obviously this model is predicated upon PCP knowledge and comfort with these types of studies. So let's talk a little bit about who is a good candidate for a home sleep apnea test. So it's a preferred test for people with suspected OSA and uncomplicated patients. And by that, I mean lack of contraindications, which are listed at the bottom. It's also important to know that home sleep apnea tests are really only used to diagnose obstructive sleep apnea. So if there's any question about whether it's central or some other mixed type picture, they're better off not going the home sleep apnea test route. But just briefly to go over the contraindications, there's 3 large buckets. The first one is respiratory disease / hypoventilation. So we're talking about things like advanced lung disease, sleep-related hypoventilation. In terms of cardiovascular, pacemaker, stroke, chronic heart failure, and the other bucket is insomnia and neuromuscular disease. Okay, so we were thinking about the IME clinic as a possible site due to initial data looking like there's room for improvement. So in 2021, our data suggested that residents at this clinic preferred sleep medicine referrals and polysomnography relative to home sleep tests. And if you look at the chart on the right, on the y-axis is the number of monthly sleep studies ordered from the IME clinic. The blue line is in-lab studies, and the orange is home sleep apnea tests. So the in-lab studies outcompete the home sleep apnea tests. We reached out to residents at the IME clinic to get a sense about why this would be the case. And they suggest that there's a vague sense of who is appropriate for home sleep apnea tests. Who would be responsible for interpreting the studies? Who would be prescribing the treatment? One resident actually mentioned that she felt as though if she ordered a home sleep apnea test, it would be similar to ordering an EKG, in that she would be responsible for interpretation unless she sent it to cardiologists. And additionally, there's a lack of knowledge about the actual logistics of ordering the home sleep apnea test and who coordinates for device pickup or delivery. And overall, this led to a cultural referral to sleep medicine. So using this information, we detailed the process map that folks at the IME clinic used for evaluation of OSA. So on the left side, if they would identify a potential candidate for home sleep apnea test, they wouldn't order the test themselves. Instead, they would refer directly to sleep medicine or order a PSG. One of the things that's important to know is that the first available appointment is around 3 to 4 months at the sleep medicine clinic. And then once patients are at the sleep medicine center, the physicians there would order the home sleep apnea test, which introduced another wait time. And one of the things that we wanted to communicate with people is that at Mount Sinai, within the Mount Sinai system, if you order a home sleep apnea test, the Mount Sinai Integrated Sleep Medicine Center will coordinate the scheduling, device distribution or pickup, as well as dealing with insurance companies if needed to get approval. After the sleep studies are completed, the data gets transferred to sleep medicine physicians for their interpretation and ultimately diagnosis if necessary and treatment. Okay. And in our heads, we put together this process map for what we'd ideally like to see folks at the IME clinic in terms of when they think about people that potentially have OSA. So on the left side, again, if they identify a candidate for home sleep apnea tests, they should just go ahead and order the test. And if there's a high pretest probability of a patient having obstructive sleep apnea, we recommended a concurrent sleep medicine referral in order to decrease the wait time. So after the patients complete the test, similar to how it was in the previous slide, sleep medicine would take care of the study interpretation and treatment. There's this thing called the IME Care app, which is an online repository of clinical guides. This is something that the residents, when we interviewed them, referred to as providing a source of different guides that they can refer to if they weren't sure about how to proceed with a case. Particularly the logistics or different information about ordering different types of tests, for example. So here is a picture of the IME app page about sleep studies prior to our intervention. So you can see at the top, it says that you will get the options to order diagnostic, PSG, CPAP, titration, or sleep night study, but there's no mention at all of home sleep apnea tests. And if you look at the bottom panel, you can see highlighted is consult to sleep medicine, which is the preferred route. So here are the interventions that we undertook during this project. The first thing was to revise the IME apps, specifically their sleep study page, where to describe the candidacy for home sleep apnea tests, and we provided instructions about how to go about getting the test. And we also provided an overview about the logistics of getting the sleep apnea test done. So we mentioned that the Mount Sinai Integrated Sleep Study Center would be responsible for the scheduling, and the sleep medicine physicians would be interpreting and treating the patients. Additionally, as I had previously mentioned, concurrent sleep apnea tests and sleep medicine referrals for patients with a high pretest probability. We also wanted to share these changes and our suggestions to the people at the IME clinic through a few different routes. The first way was through an in-person presentation to attending physicians, and the second way was through a video that was disseminated to residents at the IME clinic. And we were tracking the number of home sleep apnea test orders per month, and we sent out reminder emails to the IME firm with the lowest volume monthly, just to reiterate the benefits and logistics of the home sleep apnea test. Okay, so our aim statement was to increase the number of home sleep apnea tests ordered in the IME clinic by 20% over 6 months. We also wanted to monitor and compare the timeliness and completion rates, simultaneous referral rates, the wait time to actually get into the sleep medicine clinic, and the rates of sleep medicine follow-up. And overall, we were just curious about whether or not these interventions would actually translate to better OSA care. So this is our run chart. And the blue line is the number of home sleep apnea tests ordered per month. The magenta line is in-lab studies, and the goal line is the dotted line horizontally. So you can see for the 6-month pre-intervention period, so that's January to June 2022, the number of home sleep apnea tests in lab studies were basically the same, roughly the same per month. And after the rollout of our first intervention, which is the changes to IME app towards the end of June, you can see that the number of home sleep apnea tests really increased with a corresponding decrease in number of in-lab studies. The other interventions that we implemented were the video to residents, which we did 4 times. That's the purple line, so August through October. The presentation to preceptors occurred in November, and then reminder emails were sent out 3 times. So I guess the biggest takeaway was that there was a sustained increase in number of home sleep apnea tests above our goal line with a corresponding decrease in lab studies. And so far, we had data from 13 months suggesting that this was a sustainable intervention. Okay, and then on the new data on the right is the Mount Sinai system data in terms of the sleep studies. And I'm showing this data just to get an overall sense of the relative efficacy of our different interventions. So it looks like the first intervention was the IME app, and that occurred in late June. I think it got smudged a little bit on my marker, but it did occur in late June. And then there was a plateau in the months of August through November, and then a sharp decline in December. These were when the largely educational interventions went out. So these are things like the video to the residents, as well as the attending presentation, and then reminder emails. And then from February, there's an increase in the number of home sleep apnea tests, which actually corresponds with the all increase in terms of the system-wide data, as you can see on the right. So I think the interpretation from this is that the IME app led to an immediate increased number of home sleep apnea tests, and then the more educational things had a positive benefit, but it seems like it was short-lived. So that's what our explanation is for the first plateau. And on the right, towards the end of December and the beginning of 2023, I think that was background data suggesting that there was larger forces at play with all increased through the Mount Sinai system in general. Okay, so this chart is showing home sleep apnea tests as a fraction of total sleep studies ordered from both the IME clinic, which is the the reddish purple line, and the Mount Sinai system in general as a purple line. In the January to June 2022 period before our interventions, the fraction of HSAT orders were below that of Mount Sinai as a system. And after the interventions, it surpasses with the exception of 1 month, which is December. And it seems like it's stably increased. One major caveat is that this is across Mount Sinai system in general for the purple line. So the home sleep apnea tests are only used to diagnose obstructive sleep apnea. However, people are pursuing workups for other sleep studies. So it seems as though this purple line should be a little bit higher than it is. But nevertheless, our interventions are roughly the same, or if not a little bit higher. And then in terms of the secondary analysis, we looked at the number of home sleep apnea test orders and the number completed, as well as the completion rate. So the first piece of data I want to point out is that the completion rate for the home sleep apnea test, it's like marginally improved, but it's like not statistically significant. So it's roughly the same. The average days from order place to actually completing the home sleep apnea test wasn't improved either. The rate of simultaneous referrals in the baseline period was around 11%, and then during the intervention went up to 62%. And I think the biggest thing and the biggest takeaway was that the average time from home sleep apnea test order to sleep medicine schedule, or the date that they actually go into clinic, was reduced by like 80 days, which is statistically significant. So overall, the takeaways are the time to sleep medicine follow-up was like decreased dramatically. The rates of simultaneous sleep medicine referrals was increased, but there wasn't an effect on home sleep apnea test completion rate or the wait time. And one other thing I wanted to mention was that we also looked at the rate of simultaneous referrals and that whether or not that led to increased sleep medicine follow-up. And through our studies, you can see on the left side is those patients that completed the home sleep apnea test that had a simultaneous referral. And on the right side is the patients without the simultaneous referral that completed the home sleep apnea test. So the patients that did have the simultaneous referral had markedly better rates of sleep medicine follow-up, regardless of disease severity. So I think the takeaway here is that simultaneous referrals of sleep medicine was indeed associated with better sleep medicine follow-up. All right, so in conclusion, our interventions led to a 78% increase in monthly home sleep apnea tests over 13 months. I just want to remind everyone that the goal was 20% increase. Additionally, there was an increased utilization of home sleep apnea tests, which led to reduced time from clinical suspicion of OSA to engagement with sleep medicine. Simultaneous sleep medicine consults were associated with greater sleep medicine follow-up. Also, large gains in knowledge of OSA workup can be made with little dedicated time. Just thinking back upon what our interventions entailed, it's a video to that was like 20 minutes to residents, and then a 20-minute in-person presentation to preceptors with changes to the IME app. And one of the other things that's like important to mention is the home sleep apnea test completion rate remains poor post-intervention. That's something I'll be talking about on the next slide. And I think that these results suggest that similar interventions should be pursued at other residency programs at PCP clinics. Okay. Briefly, I just want to talk about the poor home sleep apnea test completion rates. And are these tests unique, or is it part of a larger problem out of these resident-run clinics? And what we found is that a lot of studies out there indicate there's a poor rate of cancer screening, other health maintenance tests from resident-run clinics. And some of the problems or issues that have been cited are socioeconomic factors, poor health literacy, patients being lost of follow-up, and limiting comorbidities. And one of the things I wanted to mention is that there's actually a fair number of steps that people need to take in order to complete home sleep apnea tests. I counted 5 steps. So I think the overall impression is that it is a large issue at resident clinics that have a lot of these studies completed, but due to the number of steps in the home sleep apnea test pathway, there's a lot of points at which it can go wrong. So this is a target for a potential project to address these issues and really identify the underlying factors. Okay, these are my acknowledgements. Thank you, everyone. Does anyone have any questions?